Hey there, curious minds. Welcome to the deep dive. Today, we're diving into a topic that's incredibly close to home for so many of us, how we care for the skin of our littlest humans. It sounds simple, right? But as you'll soon discover, it's actually far more complex and, well, critical than most people realize. We've got an incredible stack of research here, including this really in-depth review, Topical Therapy for Infants, evidence-based approaches from birth to 24 months. Our mission today is to navigate this wealth of information together. We want to reveal the unique vulnerabilities of infant skin, why certain treatments are incredibly effective, and maybe why others are surprisingly dangerous. You're going to walk away feeling, hopefully, truly informed about keeping those precious little skins healthy and safe.
Yeah, it's an essential discussion because, look, a baby's skin isn't just a mini version of adult skin. It's really not. It's a rapidly developing organ with very distinct properties. And these differences, they impact everything, from what gets absorbed into their tiny systems to how easily their skin can get irritated. So we're going to try and connect the science with practical, actionable care, highlighting the absolutely critical knowledge you need to have.
Okay, let's unpack this right from the very beginning. Our sources kick off by making it, well, abundantly clear just how fundamentally different infant skin is. So what are the key structural and functional differences that make infants so uniquely vulnerable, like right out of the gate?
Well, what's truly fascinating here is the sheer immaturity. I mean, just how underdeveloped infant skin is. Structurally, their outermost protective layer, what we call the stratum corneum, think of it like the skin's natural shield. It's a remarkable 30–40% thinner than an adult's. Just think about that. Now, add to that a surface area to weight ratio that's like 3 times greater in newborns.
Wow.
Yeah. And an immature epidermal junction, that's basically the glue holding the skin's outer and inner layers together. It's just not as strong.
Yeah.
And then functionally, you see increased transepidermal water loss, or TEWL.
TEWL, right.
Which is really just a fancy way of saying they lose moisture much, much more easily, so they can get dehydrated faster. They also have fewer natural moisturizing factors, those vital components that keep our skin hydrated and supple. And their skin surface pH at birth, it's often more alkaline, typically between 6.5 to 7.5.
Yeah.
Much higher than ours.
So if I'm hearing you right, this delicate, rapidly developing skin is almost like an open invitation for irritants. For a parent or caregiver, what's the absolute first thing we need to understand about how this unique skin reacts, say, to something simple like a lotion?
It means we have to be incredibly cautious, really careful. That combination, the thinner barrier, the higher surface area for exposure, increased water loss. It all dramatically enhances percutaneous absorption.
Absorption.
And this is the critical part. Substances applied to a baby's skin can be absorbed 2 to 10 times more efficiently than in an adult.
2 to 10 times.
Yes, which significantly elevates their risk of systemic toxicity.
Meaning it gets into their whole system, not just the skin.
Exactly. Into their bloodstream, affecting their entire body. And this crucial barrier function, it develops over the first 2 years of life. So making age-appropriate choices is absolutely non-negotiable. It's critical.
Wow. Okay, so we're talking about a completely different ballgame when it comes to a baby's ability to handle things.
Yeah.
Given that incredible vulnerability, especially in those very first few weeks, what does maximum caution actually look like for a newborn, from birth to 1 month?
Absolutely. Yeah, the neonatal phase is where we really need to tread carefully, maximum caution. At birth, the vernix caseosa, that cheesy protective coating, it offers a temporary barrier, which is really helpful, but sort of paradoxically, transepidermal water loss, that TEWL, is highest in the first 24 to 48 hours.
Right after birth.
Right, meaning they're losing moisture at a really rapid rate immediately. By about day 2 to 7, the skin's pH starts to shift towards mildly acidic, which is a positive step, but their barial function is still only about 60% of an adult's capacity. Then later in the month, maybe around days 8–14, natural moisturizing factors and ceramides, those crucial skin lipids, start to ramp up production, and the stratum corneum begins to thicken a bit. But the core concern during this initial month is that systemic toxicity risk. It remains profoundly high. Still 2 to 10 times greater than in adults.
And that's not just the absorption.
Right.
Yeah.
It isn't just about absorption. Their tiny bodies also have underdeveloped hepatic drug metabolism, basically. Their liver's ability to break down substances and underdeveloped elimination pathways. So they just can't process and get rid of chemicals as efficiently as we can.
That's a huge difference. So with such high risks, what is actually approved? What's considered safe for these tiny ones? And what should we consider strictly off limits? It feels like we need a very clear, safe roadmap here.
You absolutely do, and the guidance is pretty clear. For approved agents, we're talking about what our sources call level I evidence. That's strong evidence for simple emollients. Think things like petrolatum, often found in petroleum jelly.
Like Vaseline?
Exactly. And sunflower oil. But with these, there's a very strong recommendation to absolutely avoid fragrance, parabens, and sodium lauryl sulfate. Those are common irritants.
Okay.
For specific targeted issues, nystatin 0.5% is approved as a topical antifungal, but only for limited areas. Hydrocortisone, 0.51%, a very mild corticosteroid, can be used, but it's very strictly limited. Less than 7 days of use, less than 5% of the body surface area.
Not in skin folds.
Absolutely never in skin folds,
Yes.
those intertriginous areas. And chlorhexidine, 0.2%, an antiseptic, is okay for maybe a single application, rinsed off thoroughly. And critically, there's strong evidence that just using a prophylactic emollient right from birth can significantly reduce rates of dermatitis and infection later on.
Okay, that's helpful. That's what's approved. Now, the crucial part. What are the definite no-goes? What should parents never, ever use on their newborns, even for a moment?
Right. This is a list that every caregiver really must know by heart. It's vital. Retinoids, for example.
Yeah.
Common in adult acne treatments like tretinoin or adapalene. Huge. No. They can cause severe irritation, completely disrupt that fragile skin barrier, and lead to significant systemic absorption. Our sources show case studies of severe skin inflammation, something called erythroderma, in infants.
Oh, wow.
Then salicylates, like salicylic acid, found in many exfoliant products. They can lead to salicylism, which is a type of poisoning, metabolic acidosis, even Ray's syndrome. There are multiple reported toxicity cases just from topical application. Lindane, an older lice treatment, has an FDA black box warning. Neurotoxicity, seizures.
Sure.
Strictly contraindicated under 2 months. And then there's boric acid. Maybe some people remember it as a household thing from decades ago.
Yeah, I think so.
Topically, on babies. It's been linked to systemic toxicity, seizures, renal failure, and, tragically, even fatal cases in neonates. So this really emphasizes the critical safety alert in our sources. Even brief exposure to these contraindicated substances can cause severe systemic toxicity in newborns.
Just because they absorb so much more and can't get rid of it?
Exactly. That enhanced absorption plus their underdeveloped elimination pathways, it's a profound danger.
Okay, so as our little ones grow from neonates into early infancy, let's say that 1 to 6 month window, they're starting to explore the world more, maybe putting things in their mouth, and their skin is still playing catch up. What new dermatological battlegrounds start to emerge in this next phase? And how does their skin's continued maturation change the game a bit?
Right. This is where we see a gradual strengthening, but still, significant vulnerability. The stratum corneum does thicken, but it's still far more permeable than adult skin, maybe reaching about 70% of adult barrier function. The acid mantle continues to develop, getting closer to that healthy pH of around 5.5, but TEWL, that moisture loss, is still about 35% higher than adults.
So still pretty susceptible.
Very susceptible to irritants and dehydration, yes. And this stage is often when parents first encounter common conditions like atopic dermatitis, that's the chronic itchy eczema,
Right.
seborrheic dermatitis, often known as cradle cap, or sometimes it affects the diaper area too, diaper dermatitis, the classic diaper rash, candidiasis, which is a yeast infection that loves warm, moist spots.
The diaper area.
Exactly. And impetigo, which is a bacterial skin infection. All of these typically require some form of topical treatment.
Okay, so our sources provide clear, evidence-based interventions for these common issues. What are the first-line therapies we should be reaching for now?
Yeah.
And just as importantly, what should we absolutely continue to avoid, even though their skin has matured a bit more?
Okay, so for atopic dermatitis, consistent application of emollients, maybe every 6-8 hours, is still the first line of defense, with hydrocortisone 1% used for those eczema flares when they happen. For seborrheic dermatitis, ketoconazole 1% foam, maybe twice a week, or a zinc pyrithione shampoo can be very effective. Diaper dermatitis often responds well to zinc oxide paste 40%, that thick barrier cream, applied with each change, and nystatin added if you see signs of a candidal yeast infection.
Oh.
Impetigo, since it's bacterial, is typically treated with mupirocin 2% ointment. However, the caution list actually expands in this age group. Potent and super potent corticosteroids, like clobetasol and betamethasone, definite no-goes. Still,
Why is that? What are the risks there?
huge risks, including HPA axis suppression, where the body's natural hormone production gets disrupted. This can impact growth, development.
Serious stuff.
Very serious. Plus, permanent skin changes like striae, stretch marks. Our sources even cite a case of Cushing syndrome, a severe hormonal disorder in a 4-month-old treated with clobetasol,
Wow, just from a cream.
just from a potent cream. Then, calcineurin inhibitors like tacrolimus and pimacrolimus. These are powerful immune-modulating creams. They carry an FDA black box warning for kids under 2, largely due to concerns about how much of these potent medicines babies absorb systemically. Topical antibiotics like neomycin and bezitracin, they can actually lead to contact dermatitis. There's a surprisingly high 25% sensitization rate in infants.
So they can become allergic to the antibiotic itself.
Exactly. And local anesthetics like benzocaine and lidocaine, they carry specific FDA warnings for infants under 6 months. Risks of methemoglobinemia, that's a blood disorder affecting oxygen and seizures. It's just critical to remember. Systemic absorption in this 1 to 6 month age group can still be 2,000 times greater than in adults, even if their skin looks perfectly intact. Careful selection is paramount.
That's a lot to keep track of. Okay, so as we move into late infancy, say 6 to 12 months, our sources introduce another fascinating element, the skin microbiome. It's like this whole invisible ecosystem living on their skin. How does its development impact our treatment choices now? And what are the specific validated therapies and continued prohibitions for this age group?
Yeah, the microbiome. This raises a really important question for me and for the field. How do our interventions affect that delicate developing skin microbiome? This invisible ecosystem goes through a really rapid maturation timeline. It starts with maternal flora at birth, then quickly colonizes with beneficial bacteria like Staphylococcus epidermidis, then it diversifies and eventually establishes other important microbes like Corynebacterium and Cutibacterium acnes. You start seeing site-specific patterns becoming clearer by 9-12 months, like the forehead microbiome looks different from the arm crease.
Interesting. So what does that mean for treatment?
Well, the therapeutic implication is that our treatment should actively try to preserve microbiome diversity whenever possible. This means a judicious, really smart use of antibiotics and antiseptics is key. We want to avoid disrupting those normal beneficial colonization patterns if we can help it. In fact, emerging research suggests that microbiome-sparing approaches might actually reduce the incidence of chronic inflammatory skin conditions later in life.
That's a powerful thought, that our early choices can have such long-term effects, almost like gardening a healthy internal environment.
Exactly. It's a shift in thinking.
So what are the go-to treatments now that their skin is a bit more robust, maybe 6, 12 months? And what new substances are joining the prohibited list for this age?
Okay. For atopic dermatitis, consistent emollients 2-3 times daily. Still the foundation. Hydrocortisone 1-2.5% can be used for flares, maybe twice a day for 7-10 days. We can now carefully consider pimacrolimus 1% for sensitive areas like the face or skin folds. And for severe flares, wet wraps can be a very effective option under guidance. Seborrheic dermatitis. Ketoconazole 2% shampoo 2-3 times weekly is an option now, often alternated with zinc pyrithione or selenium sulfide shampoos, and hydrocortisone 1% for any really inflammatory lesions. Diaper dermatitis still relies heavily on zinc oxide 40% with each change. Nystatin if you see those telltale satellite pustules that suggest yeast. And maybe hydrocortisone 1% for just 3 to 5 days if it's particularly severe. But as for prohibited ingredients, this is crucial. Fluorinated corticosteroids. Things like fluocinamide and desoxymetasone, they are high risk.
Why these specific ones?
They're stronger, more potent steroids. They penetrate deeper, increasing the potential for that HPA axis suppression we talked about and skin thinning or atrophy. Our sources cite a really compelling case of iatrogenic Cushing syndrome, meaning pause by medical treatment in a 10-month-old, just after 4 weeks of daily fluocinamide use.
Wow, 4 weeks.
Yeah. Coal tar derivatives also carry moderate to high risks. Photosensitivity, even potential carcinogenic concerns with long-term use. Formaldehyde releasers, often hidden in preservatives. Avoid them. Alcohol-based products over 10% isopropyl alcohol, also noted with moderate to high risks. Contact dermatitis, barrier disruption, and even things often seen as natural, like essential oils, tea tree, or lavender, they're on the list too. Risks of contact dermatitis, barrier disruption, even potential hormone disruption.
It really sounds like applying that rule of 5s. The formula potency, concentration, surface area, frequency, duration is absolutely critical for assessing risk here, especially as the list of things to avoid just keeps growing.
It absolutely is. That formula is an indispensable tool for clinicians. It helps quantify the risk.
Okay, so as infants transition into toddlers, say 12 to 24 months, we see some definite shifts in how we approach their skincare, right? What changes in our management philosophy, and what common conditions are most prevalent in this incredibly curious, mobile, and, let's face it, active age group.
Right, toddlers. Here, the management paradigm really shifts. We move from primarily barrier-focused approaches, just moisturizing, to more inflammation-focused ones, using more targeted treatments. There's an increased emphasis on targeted rather than generalized therapy. And we also move from passive to active application techniques. Toddlers are squirmy.
Tell me about it.
Exactly. They often resist treatment, making vehicle selection really critical for compliance. Sprays and foams, for instance, are often preferred because they're just easier to apply quickly before they wiggle away.
Makes sense.
No.
What conditions are we seeing most?
Well, atopic dermatitis continues to be very common, affecting maybe 25–30% of toddlers, often with a flexural distribution popping up in the creases of joints like elbows and knees. Contact dermatitis impacts maybe 15–20% as they explore their world, touching everything, getting exposed to new irritants and allergens. Diaper dermatitis actually starts to decrease as they get older, more mobile, maybe starting potty training. But impetigo, that bacterial skin infection, often increases, usually linked to daycare attendance where infection spreads so easily.
Ah, the daycare effect.
Exactly. And urticaria, or hives, is also commonly seen, often triggered by food or environmental factors as their diets and surroundings expand.
So, with these shifts in conditions and, frankly, behavior, which moderate potency corticosteroids might become safe for limited use, and what novel agents are now established for this age group, and critically, what remains strictly contraindicated, even as they approach 2 years old.
Okay, good questions. Moderate potency corticosteroids like triamcinolone 0.025, 0.1%, mometasone 0.1%, fluocinolone 0.01%. They are now considered potentially safe for limited intermittent use in toddlers, but I really have to emphasize limited, no more than 7–10 days, applied to less than 10% of the body surface area, strictly avoiding occlusion, like under diapers or tight clothing, and limited to maybe 2 or 3 courses per month. These are still strong medications.
Understood. Limited use.
Very limited. Now, for novel agents, crisaborole 2% ointment, that's a PDE4 inhibitor, it blocks a specific enzyme involved in inflammation. It's approved for atopic dermatitis in patients 3 months and older, and the good news is it shows minimal systemic absorption, making it quite safe. Tacrolimus 0.03% ointment, a calcineurin inhibitor we mentioned earlier with the black box warning. It now has established safety data specifically for toddlers 2 years and older. So despite the lingering warning, it's used carefully in this age group. Metronidazole 0.75% gel is also well tolerated for specific conditions like perioral or perianal dermatitis. However, several formulations remain high risk. Calcipotriene, a vitamin D analog, contraindicated under 12 years, risk of hypercalcemia, too much calcium in the blood.
That sounds serious.
It is. Our sources highlight a case report of an 18-month-old who developed severe hypercalcemia from topical use. Imiquimod, also contraindicated. Minoxidil, there's a concerning case series of toddlers developing tachycardia, rapid heart rate, and cardiac stress from topical application. And Fluorosil, also strictly contraindicated for these younger ages.
It makes perfect sense that toddlers' high hand-to-mouth activity is a particular risk factor here, making vehicle selection critical for safety. They just get into everything, don't they?
Exactly. Anything you put on their skin can very easily end up in their mouths. Potential for accidental ingestion, systemic effects. That's why we need to be so mindful of what we're putting on their skin and how it's formulated.
Looking ahead then, our sources point to some really exciting pipeline therapies, things that could truly revolutionize how we treat infant skin conditions. What are some of these novel delivery systems and emerging biologics? Some sound like they're straight out of science fiction.
Oh, this is where innovation truly shines. It's really exciting stuff. We're seeing advancements in novel delivery systems like microencapsulation technology.
Microencapsulation.
Yeah, it basically reduces systemic absorption by like 40–60% while maintaining the effect right where you need it on the skin. Think of it like tiny targeted shields for the medication. Then there are nanoparticle carriers designed to deliver medications specifically to certain skin layers, minimizing that systemic exposure. And biomimetic vehicles engineered to mimic the skin's natural lipid composition. That helps enhance barrier repair.
Wow.
And finally, controlled release technologies. These promise sustained therapeutic levels with minimal systemic exposure over time, ideal for this vulnerable population. And for emerging targeted therapies, dupilumab, for instance. It's a cutting-edge biologic. It essentially blocks specific signals, IL-4 and IL-13, that cause inflammation and atopic dermatitis.
And that's approved now?
Yes, it's now approved for babies as young as 6 months. And clinical trials, remarkably effective, helping about 80% of patients see a significant, like ESI 75 improvement in their eczema.
That's huge.
It is Huge. Tapinarof, which is an AHR modulator, and roflumilast, another PDE4 inhibitor. They're also in advanced trials for toddlers, offering new ways to manage inflammation.
And what about that microbiome revolution you mentioned earlier? How is that translating into new therapies right now? Is anything actually available?
Well, it's getting there. We're seeing therapies like commensal-derived antimicrobial peptides being developed. These are designed to specifically target harmful bacteria, like Staphylococcus aureus, which often aggravates eczema.
Right, the bad bugs.
Exactly, while crucially preserving the beneficial flora that keeps skin healthy. And even more exciting, live biotherapeutic products. Things like topical Roseomonas mucosa, they're showing real promise in clinical studies for conditions like atopic dermatitis. This really represents a paradigm shift, moving towards precision medicine, working with the body's natural defenses to prevent chronic disease, rather than just constantly treating symptoms after they appear.
Okay, so beyond the new drugs, which sound amazing, there's still a strong emphasis on optimizing vehicle selection, creams versus ointments, and implementing clear, evidence-based guidelines. How can we ensure the best outcomes for infants, sort of integrating all this new knowledge?
Absolutely. Selecting the right vehicle is paramount. It really matters. Ointments, for instance, are often ideal for the youngest ones, 0 to 6 months. They're occlusive, moisturizing, often preservative-free, best for really dry skin conditions, barrier repair. Creams are good for all ages, really. They offer balanced moisture, often more cosmetically acceptable than greasy ointments.
Easier to rub in.
Exactly. Lotions are better maybe from 6 months up, especially for hair-bearing areas, while foams and solutions are often preferred for toddlers over 12 months. Easier application, better compliance, good for specific sites like the scalp. And research shows that getting the vehicle right can improve treatment adherence by up to 45%.
45%.
Yeah. And clinical outcomes by 30% in pediatric patients,
Yeah.
just by choosing the right base. Our sources also provide a really clear 4-phase framework for how clinicians should approach this in practice. It's very practical. First, the assessment phase. Pinpoint the exact age, calculate the body's surface area involved, assess the skin's barrier integrity, identify the specific anatomical sites needing treatment. Second, the prescription phase. Select the most age-appropriate agent, the optimal vehicle, calculate the maximum safe quantity, and set clear duration limits. Super important. Third, the education phase. This is so incredibly important. Demonstrate the application technique. Review warning signs. Set realistic expectations. Provide clear written instructions.
Can't stress that enough.
Absolutely.
Yeah.
And finally, the monitoring phase. Schedule appropriate follow-up, document the outcomes, assess for any adverse events, and adjust the regimen as needed. It's a cycle.
And the fingertip unit, or FTU guide, that sounds like an incredibly practical tool to ensure correct dosing, especially when we're dealing with such small bodies and potent medications.
It is indeed very practical. 1 FTU, basically the amount squeezed from a standard tube onto the fingertip pad from the tip to the first joint. That equals roughly 0.5 grams of topical medication. You then adjust this, maybe dividing it for mid or high potency steroids. This simple guide helps avoid both underdosing, which means the treatment won't work, and critically, overdosing, which, as we've discussed extensively, carries significant risks of systemic absorption in infants.
Wow, what an essential deep dive this has been. It's crystal clear that topical therapy for infants is, well, a really nuanced field. It demands such careful consideration of age-specific skin properties, those potential risks, and the evolving science. From the delicate neonatal period right through to adventurous toddlerhood, our approach has to constantly adapt.
It really does. My absolute key take-home messages for you listening are these. First, always select the least potent effective agent you can for the shortest duration necessary. Less is often more. Second, always consider those age-specific differences in skin barrier function and drug metabolism. They matter hugely. Third, carefully match the vehicle, the cream, the ointment, the lotion to the patient's age and condition. And finally, always provide explicit, clear instructions on the quantity, frequency, and duration of application. These principles are your absolute best guide for safety and efficacy.
Okay, so what does all of this mean for you, our listener, as you encounter discussions or make choices about infant skincare? Beyond the immediate practicalities, what's maybe a bigger question this deep dive sparks for you to consider?
That's a great question. I'd encourage you to think about how much more we still need to understand about the long-term impacts of early microbiome disruption. We talked about the skin microbiome, right? But what are the effects not just on skin health down the line, but potentially on overall immune development, systemic health? It's a really compelling thought for how we might shape future preventative strategies, moving beyond just treating symptoms to truly nurturing a child's foundational health right from the start. What does that look like?
A truly insightful point that leaves us with so much to ponder, thinking about prevention, not just reaction. Thank you so much for joining us on this essential deep dive. We really hope you feel more informed and empowered. Until next time, keep that curiosity alive.